Left lateral position. Body positioned on left side with spine straight or slightly curved, weight distributed along left shoulder, hip, and leg. The anatomical advantage? Left side positioning moves the gravid uterus away from the inferior vena cava, the body's primary venous return vessel that runs along the right side of the spine. Blood flow from lower extremities returns unobstructed to the heart. Cardiac output increases by up to 25%, and placental perfusion reaches maximum efficiency, optimal from second trimester onward when uterine weight becomes significant, with benefits intensifying through third trimester. Maternal effects include reduced lower back pressure, decreased swelling in legs and feet, improved kidney function, and waste elimination. This is not subjective comfort advice, but measurable hemodynamic optimization. Left side sleeping quantifiably increases oxygen and nutrient delivery to the fetus compared to all other positions. Right lateral position. Body positioned on right side with identical mechanical setup to left side positioning, but with subtle circulatory compromise. The uterine weight now rests closer to the inferior vena cava, creating partial compression that reduces venous return efficiency by approximately 10 to 15% compared to left side. Acceptable throughout pregnancy when left side becomes uncomfortable or during natural position shifting, but not the primary recommended position. Maternal effects remain largely positive. Spine alignment maintained, breathing unrestricted, organ compression minimal. The distinction matters most in third trimester when every percentage of blood flow optimization contributes to fetal growth and oxygen saturation. Right side is not dangerous but represents measurably suboptimal circulation, the difference between good and best rather than safe and unsafe. Supine position. First trimester. Body positioned flat on back with spine against mattress before uterus. Expands beyond pelvic cavity. In weeks 6 through 14, the uterus remains small enough that its weight creates no vascular compression, making back sleeping mechanically equivalent to non-pregnant positioning. Blood flow remains unimpeded. No circulatory compromise exists. Comfort is typical. This window allows back sleeping without physiological consequence. Maternal effects: neutral positioning without strain, familiar sleep posture maintained. First trimester back sleeping is genuinely safe, not merely tolerable. The anatomical mechanics simply do not create circulatory problems until uterine size increases beyond approximately 16 weeks when the fundus rises above the pelvis. Supine position second and third trimester. Body positioned flat on back after week 16, when uterine weight creates direct compression of the inferior vena cava against the spine. This compression reduces venous return by up to 40%, decreases cardiac output significantly, and triggers supine hypotensive syndrome in approximately 8% of pregnant women. Sudden blood pressure drop causing dizziness, nausea, shortness of breath. Fetal impact is direct. Reduced maternal cardiac output equals reduced placental blood flow equals measurable decrease in fetal oxygen saturation. Some women develop compensatory circulation that partially mitigates compression, but the mechanism is unreliable. Maternal effects include potential lightheadedness upon waking, increased back pain, exacerbated heartburn. The advice against back sleeping is not overcautious. It is vascular mechanics, and while brief periods cause no permanent harm, sustained supine positioning creates measurable fetal oxygen reduction. Prone position. Early pregnancy. Body positioned face down on abdomen during first trimester when uterus remains within pelvic protection and breast tenderness has not intensified. Mechanically possible and creating no fetal compression risk until approximately 12 to 16 weeks when expanding uterus makes the position physically uncomfortable before it becomes physiologically problematic. No circulatory compromise exists, no pressure on growing fetus occurs. The uterus is too small and too protected. The position becomes naturally self-limiting as abdominal growth makes lying prone impossible without significant discomfort. Stomach sleeping does not harm the fetus when it is still physically comfortable. Your body's discomfort signals the endpoint before any risk begins. Elevated upper body position. Upper torso raised 30 to 45 degrees using wedge pillow or adjustable bed base creating inclined positioning that is neither fully upright nor flat. This angle reduces gastric acid reflux by utilizing gravity to keep stomach contents down, particularly valuable in third trimester when progesterone relaxed, esophageal sphincter, and uterine pressure on stomach create severe heartburn. Breathing improves as diaphragm pressure decreases, particularly beneficial for women experiencing pregnancy-related shortness of breath. Circulation remains adequate as long as the incline prevents rolling fully onto back. The elevation must maintain some lateral tilt. Elevation addresses specific symptoms effectively without creating new circulatory problems, making it genuinely therapeutic rather than merely palliative. Semi-reclined supported position. Body reclined at 45 to 60-degree angle with pillow support behind back, creating seated sleeping hybrid that avoids full supine positioning while providing back support. This compromise position allows some vena cava decompression while accommodating women who find full lateral positioning intolerable. Effective in third trimester when heartburn, shortness of breath, and hip discomfort make traditional sleeping positions untenable. The key mechanism, maintaining enough lateral tilt, even slight, to shift uterine weight off the vena cava prevents full compression. Maternal. Comfort often improves significantly versus pure side lying. Semi-reclined positioning represents practical harm reduction when optimal positions fail, acknowledging that actual sleep quality matters for maternal and fetal health, even if positioning is theoretically suboptimal. Tightly curled fetal position. Body curved with knees drawn fully toward chest, spine maximally flexed, creating compressed C shape. While intuitively protective, this positioning restricts diaphragm expansion and reduces lung capacity by up to 20%, compromising oxygen intake exactly when pregnancy already increases oxygen demands. Hip and knee joints held in extreme flexion for extended periods create morning stiffness and exacerbate pregnancy-related joint pain. The compression offers no fetal protection. Amniotic fluid provides all necessary cushioning regardless of maternal positioning. Creates potential restriction of already compromised circulation if combined with backlying. The psychological comfort of curling protectively does not translate to physiological benefit and may actively impair respiratory efficiency. Loose side lying position. Body positioned laterally with slight natural spinal curve, legs gently bent rather than tightly drawn, head and neck aligned with spine. This achieves optimal balance between circulatory efficiency and musculoskeletal comfort. Spine maintains neutral alignment, preventing strain. Breathing remains unrestricted. Circulation optimization of lateral positioning is maintained without compression from excessive curling. This becomes the sustainable position for extended sleep periods throughout second and third trimesters. Joint positioning remains comfortable without creating morning stiffness. Loose side lying represents the intersection of circulatory optimization and practical sustainability. The position you can actually maintain for hours rather than the theoretically perfect position you will abandon after 20 minutes. Strategic. Pillow support configuration. Full-length body pillow between knees and under abdomen, standard pillow supporting head and neck. Optional small pillow supporting lower back curve. This support system maintains lateral positioning by preventing rolling, cushions the weight of the gravid abdomen to reduce ligament strain, and keeps hips and spine aligned to prevent sciatic nerve compression. The between knee pillow is mechanically critical. It maintains parallel hip alignment, preventing the top leg from rotating the pelvis and creating lower back strain. Under belly support becomes essential in third trimester when abdominal weight creates pulling sensation on round ligaments. This is not luxury comfort, but structural support that enables maintaining optimal positions throughout the night. Proper pillow support transforms theoretically correct positioning into practically sustainable sleeping. The mechanical assistance that allows your body to maintain beneficial positions during actual sleep rather than conscious rest. Natural position shifting pattern. Unconscious movement between positions throughout night, typically shifting every 45 to 90 minutes in response to pressure point discomfort, circulation changes, or fetal movement. This natural pattern continues during pregnancy and serves protective function, preventing sustained compression of any single blood vessel or nerve, redistributing pressure across different contact points and allowing brief periods of suboptimal positioning without cumulative harm. The body typically self-corrects away from truly problematic positions. Most women who roll onto back during sleep wake within minutes from discomfort or circulation changes. The goal is not rigid position maintenance, but establishing left lateral as the starting and returning position. Perfect position adherence throughout 8 hours is neither achievable nor necessary. The body's natural movement patterns provide adequate protection as long as you begin sleep in optimal position and return to it after waking.